Hello aspirants, welcome to GDC English classes. I hope you are too busy with your Gpat preparation. So quick maintain that. I think only few days only left. I think around 2 days only left for your Gpat preparation. So put your 100% effort on this last days. So no need of saturation, no need of over excitement, no need of preparation. So just going forward. So what you want to do, just do it regarding your preparation. It may be going for revision on the major subjects or going for revision on the minor subjects. But try to stabilize your brain with your self-confidence because it is not easy always because telling is always easy, you know that. But maintaining self is very, very difficult. But yes, you can make it, no problem. And only last 2 days are left for your GPAT preparation. But you are very serious about your GPAT preparation, that is sure. But be conscious what you are doing and be conscious what you are studying that should be enter into your brain barrier or not. Okay. So in this video, we will discuss old questions from the pharmacology from Gpat 2020 question paper. So let's have the discussion. So the first question is here. Following page represent the first question here. The following page represent antibiotic and its source. Identify the correct way. Identify the correct way. So rhizoflumin is an antifungal drug. It is from the bacteria. Here options polyenes like polyen antibiotic amphotericin B from the fungi. Colistin a antibiotic from the fungi. Macrolides from the actinomyces. So rhizoflumin is from the penicillium rhizoflumin fungi. Polyen from the bacteria and colistin is also from the bacteria. The correct answer is here. Macrolides are from the actinomyces. Macrolides are from the actinomyces species. Nothing but comes under bacteria. So the correct pair is the macrolide antibiotics naturally from the actinomyces species, a type of bacterial system. And here the list. So fungi is the organism will give penicillin, cephalosporin, rhizoflumin. Bacteria will give polymyxin B, colistin, bacillus, tyrosine, astrona, and actinomyces will give aminoglycoside, tetracycline, chloramphenicol, macrolides, polyenes. So like these questions also appearing in your examination, definitely chance will be there. So this table will give the clarification. So the simple table will make you easy to remember. And in upcoming June, GDC is going to start its new batch, especially from GDC English classes. Who are from the South India region students, they can easily understand the English language, the quality and content of the Gpat Distance Center GDC. So subscribe to our GDC English classes and inform to your classmates, your juniors who are willing to take part of 2026 Gpat as well as 2027 Gpat examination. So GDC English class is going to launch a new batch from the upcoming June. Okay. And not only GPAT, including NIPER, drug inspector, pharmacist, everything. And I hope you know that GPAT is only not for only GPAT examination. Once you studied the GPAT throughout 1 year or since 2 years, definitely that GPAT will make you the pathway easier for to make NIPER, to make pharmacist exam, to make drug inspector exam. Any other pharma competitive or government exams are easy for you if you are really enthusiastic and really passionate for the GPAT preparation. Because GPAT is like a ocean syllabus. And what is the next question? Regarding the next question, so it is like the basic anatomy question. Mechanical digestion in mouth, in which food is mixed with saliva and the movement of food from the mouth into the stomach. So simply mechanical digestion in mouth, that's we know that started in the mouth, and in which food is mixed with the saliva and movement of the food from the mouth into the stomach is. So mastication, deglutination, propulsion, segmentation, mastication, segmentation, and propulsion. So the answer is very easy. You know that mastication and deglution is the answer. Mastication, deglution is the answer. So this is a basic question from anatomy. You will answer easily. So what is simply mastication? So regarding the mastication starts in mouth. Mastication or chewing in the GIT tract is the First mechanical process by which food items are torn or cut into tiny pieces, crushed or ground into the soft ball. So simple logic, the digestion will start here. The large food particles are slowly grind into the small particles. What is deglutition? So deglutition are swallowing, a mechanism that transfer food from mouth into the stomach. So deglutition is nothing but a transfer the grinded food from mouth to the stomach. Swallowing is an essential and complex behavior learned by very early in the development and it is a voluntary process. It is a voluntary process. If you want to chew, if you want to swallow, we can. It is a voluntary process. Next time. So rosacea, generally rosacea when you see rosacea means family from the pharmacology. So here, what is simply here I am telling. So rosacea is a skin condition that affect teenage people, old age people, only men, and adults between 30 to 60 years of age. Okay. So these are a generalized questions. Most probably we can answer or maybe not, but go through in previous year question papers will give some idea. So teenage people, old age people, only women, and the answer is adults between age of 30 to 60 will get the condition rosacea. So let's see the discussion. So what is regarding this skin condition? Regarding this condition, so rosacea, chronic skin disorder which affect the central facial area. If you see the picture also, so it is mainly affecting the central facial area. So what is it is simply so onset during middle age adults of 30 to 60, with women being affected somewhat earlier than men. It is characterized by redness, tiny pimples, not sorry, noticeable blood vessels, usually in the central area of the face. So the name itself indicating rosacea, it is a skin condition. So rosacea is nothing but rose color. So appearance of red color rashes on the skin, especially in the central face. So central area of the face. So rosacea is a condition observed in case of age in between 30 to 60. 30 to 60. And next question. A typical long bone consists of following parts except. So this is also anatomy related question. So a typical long bone consists of following parts except diaphysis, trabecule, epiphysis, periosteum. Periosteum means peri around the bone. And epiphysis you know. Diaphysis you know. Generally you cannot go to the trabecular part in case of bone. So that's why a typical long bone consists of following part except. So answer is the trabecule. Trabecule is the exception for this question. Answer is trabecule. So let's have a look on the discussion. Let's have a discussion on the localization. Sorry, discussion. So this is the epiphysis. This is also epiphysis, and this is the diaphysis. So and diaphysis consists primarily compact bone with central medullary canal, which includes fatty yellow bone marrow. So diaphysis is a compact bone with a tight structure, and it includes a fatty yellow bone marrow. Next, epiphysis. Regarding epiphysis, consisting an outer covering of compact bone with a spongy bone inside. Spongy bone. So there is a gaps in the arrangement of the structure. Spongy bone. You know the normal sponge. Okay. And next, trabecule. A thin columns and okay. So trabecule is a thin column and plates of the bone that create a spongy structure in a cancellous bone which is located at the end of the long bone and the pelvis, ribs, skull as well as a vertebrae also. Next. So regarding the next year, antifungal agent 5-fluorocytosine converted to active metabolite 5-fluorouracil by one of the following fungal enzymes. So generally 5-fluorocytosine. 5-fluorocytosine is an example of antifungal drug. It inhibits DNA synthesis in the fungi. Before that, this drug should enter into the fungal cells, should convert to active drug 5-fluorouracil. So conversion of 5-fluorocytosine or flucytosine into the 5-fluorouracil with the help of an enzyme is known as so options are cytosine deacetylase, cytosine reductase, cytosine demethylase, cytosine deaminase. So, for conversion of flucytosine to fluorouracil, there should be removal of a amine group. So, there should be requirement of deaminase. So, here the enzyme is cytosine deaminase is the answer. Cytosine deaminase converts inactive form of antifungal drug to the active form of fungal drug, flucytosine to 5-fluorouracil, that having antifungal activity by interfering with the DNA synthesis in the fungi. So the answer is very clear. The answer is cytosine deaminase. Cytosine deaminase. So here it is the drug. Generally, flucytosine is commonly combined with flucytosine is commonly combined with amphotericin B, a natural antifungal drug, antibiotic. Antifungal antibiotic amphotericin B combined with flucytosine. Amphotericin B forms a pores on the fungal cell wall. Through that pores, flucytosine enters easily into the fungi and converts to active drug and interfere with the DNA synthesis. So this is a flucytosine amphotericin B. Amphotericin B increase the penetration of flucytosine into the fungal cell, converts to 5-fluorouracil, 5-fluorodeoxyuridine monophosphate, and prevent the conversion of deoxyuridine monophosphate to deoxythymidine monophosphate by inhibiting time delayed synthase enzyme and interfere with the DNA synthase. But conversion of flucytosine to 5-fluorouracil requires cytosine deaminase enzyme. Cytosine deaminase enzyme. Next question is here. So one of the following is not a chemical or histochemical change that occurs in infarction of heart, myocardial infarction. So one of the following is not a chemical or histochemical change that not happen in case of myocardial infarction. So generally options are like decrease in sodium, glycogen depletion, influx of calcium. Generally decrease in sodium will take place in this myocardial infarction because of the decreasing the function of heart. Especially this condition is due to decrease in oxygenated blood supply to the particular part of the heart. And glycogen depletion, decreasing glycogen, decrease of glucose, and influx of calcium, increase in lactic acid. Increase in lactic acid is not a part of this myocardial infarction, not a part of myocardial infarction. So the answer is the increase in lactic acid is not there. Sorry for my inconvenience. So decrease in the sodium. So decrease in the sodium is one of the following, not a chemical or histochemical change that occurs in the infection of the heart. So first, what is infarction? What is myocardial infarction? Regarding the myocardial infarction, tissue death or necrosis due to inadequate blood supply to the affected area. It may be caused by blocking of arteries, rupturing of arteries, mechanical compression or vasoconstriction. So infraction is nothing but a death of the tissues. So death of the tissues due to inadequate blood supply to the affected area. What are the changes in the early infarcts? Early infarcts. So infraction is nothing but a death of the heart cells because of lack of oxygenated blood supply. So the early infarcts by special techniques like electron microscopy, chemical and histochemical studies. So early infarcts, if there is any small infarcts are there, they can be identified by the special techniques like electron microscopy, chemical and histochemical studies also will be easily identified the early infarctions in the heart. Early infarctions in the heart. So this is regarding electron microscopic changes, so chemical and histochemical changes. So next question is, accept one of the following pairs. Accept one of the following pairs. Represent drugs used in the treatment of glaucoma and their primary mechanism. Select the wrong pair from the following. So the question is given. Here list of the following drugs are acting on glaucoma along with their mechanism, and among this select the wrong pair. Select the wrong pair. So let's have a look here. For example, topical prostaglandin analogs increase aqueous humor outflow. Topical beta adrenergic blocker decrease aqueous outflow. Topical myotics increase aqueous outflow. Topical carbonic anhydrase inhibitor decrease aqueous humor formation. Decrease aqueous humor formation. So topical carbonic anhydrase inhibitors decrease aqueous humor formation. Topical myotics. So among this, which one is the wrong one? Among this, which one is the wrong one? So definitely the answer will be the topical beta adrenergic blocker decrease the aqueous outflow. So they are not involving decreasing aqueous outflow. So that is a wrong way. That is a wrong way. So let's see the discussion for more clear information. So you know that glaucoma is nothing but glaucoma is a ocular hypertension. Rise in the intraocular pressure. Rise in the pressure in the eye. Intraocular within the eye. And glaucoma is also known as ocular hypertension. Also known as ocular hypertension. And drugs used in glaucoma. So you can see this. So decrease aqueous secretion, increase aqueous outflow with beta blockers, alpha 2 agonist, carbonic anhydrase inhibitor, increase clavicular outflow, myotics alpha 2 agonist, and increase uveoscleral outflow, prostaglandina and lux. Prostaglandina and lux. So here the mechanism of following MCQ, mechanism of antiepileptic effect of lamotrigine. So lamotrigine is one of the new class of antiepileptic drug like phenytoin, carbamazepine, valproic acid. Lamotrigine is also generally a common antiepileptic agent in the particular treatment of seizures. And this lamotrigine is selectively block sodium channel and decrease the firing of neurons and decrease the frequency of seizures also. So regarding inhibition of glutamate release, blocking of NMDA receptor, inhibition of sodium channel, inhibition of calcium channel, inhibition of calcium channel. So as you know that inhibition of sodium channel like valproic acid, phenytoin, etc. Lamotrigine is also block the sodium channel. Lamotrigine is also block the sodium channels. The answer you know that already. So inhibition of sodium channels is a mechanism of action by our lamotrigine. So lamotrigine is a broad spectrum antiepileptic. It acts by prolongation of sodium channels in the inactivation state and suppression of frequency of firing of the neuron. So block the sodium channels in the inactive state, maintain the sodium channels more time in the inactive state. Maintains sodium channels more time in the inactive state. Yes, if you want it, here we can mention clearly drugs prolong the sodium channels in inactivation state. So increase the duration of sodium channel in inactive state. Inhibition of excitatory glutamate synapse, facilitation of GABA function, and inhibition of T-type calcium channels. So these are the list of the drugs mentioned along with their common mechanism of action as a anti-epileptic drugs. Next question. Regarding the next question, cotrimoxazole, a combination of trimethoprim with the sulfamethoxazole. Which of the following statement is correct about cotrimoxazole? So cotrimoxazole is a combination. It is generally a bactericidal activity. So individually both the drugs are bacteriostatic. In the combination these are bactericidal and they are having many clinical application, treatment of urinary tract infection, treatment of some traveler's diarrhea, and treatment against the vancomycin resistant infections, treatment against methicillin resistant staphylococcus aureus infections, like that. So here these are the points about cotrimoxazole, that is combination of trimethoprim with sulfamethoxazole, and among these statements which one is the correct you have to choose. So regarding first one, cotrimoxazole is contraindicated during the pregnancy. Most effective ratio trimethoprim sulfamethoxazole in the 20:1. So sulfamethoxazole should be 20 and 1 will be the trimethoprim. Trimethoprim sulfamethoxazole are administered in a dose ratio of 5:1. Generally sulfamethoxazole will be the 5:1 and 1 will be the trimethoprim. Cotrimoxazole is effective in treating respiratory infections, not only respiratory infection, it also is in other conditions also. So here cotrimoxazole is contraindicated in pregnant women because on high dose or continuous usage, cotrimoxazole may decrease the folic acid supplement in the pregnant women and may also defect the fetus growth also. So the answer will be the so cotrimoxazole is contraindicated during the pregnancy. Yes, as I mentioned earlier, cotrimoxazole is a combination of sulfamethoxazole plus trimethoprim. It is a sequential blocker, inhibit the two enzymes in the folic acid metabolism in the bacterium and suppress the folic acid synthesis in the bacterium and decrease the RNA DNA synthesis in the bacterium. And cotrimazole is effective drug because of its bactericidal nature. It acts by kills the bacterium by interfering with folic acid in the bacterium. Next, mitomycin C. So, mitomycin C is one of the mitomycin C is one of the cancer antibiotic anti-cancer antibiotic. So it available from the source Streptomyces pustulus, Streptomyces verticillus, Streptomyces antibioticus, Streptomyces caspitosus. Okay, these are the list of the organisms. From these organisms, from where our drug is coming. So from the Streptomyces caspitosus, Streptomyces caspitosus. Okay, so like these questions also, there is a chance to appear. There is a chance to appear in the Gpat examination. Gpat examination. Streptomyces caspitosus. So here the list of the some of the list of important drugs along with their source. So you can go through table and definitely like these questions. There is a chance to appear in your Gpat examination. So in our Gpat, especially GDC Gpat modules, everything is available. I hope you already gone through. If you have time, once go through like this tables also. Next, the next question is here. Identify the diuretic which cause hyperuricemia, increasing uric acid levels in the blood, tend to rise serum calcium and also cause magnesium depletion. Magnesium depletion. So which are the following diuretic? Yes, generally diuretics like thiazide diuretics, they increase the uric acid levels, may lead to development of gout, and they also increase the calcium levels in the blood. Thiazide diuretics are calcium sparing diuretics. They decrease the excretion of calcium and increase the levels of calcium in the blood body. So estrazolamide, furosemide, mannitol, chlorothiazide. So estrazolamide is a carbonic anhydrase inhibitor. So it having these properties are not belong to this. Furosemide is a loop diuretic. Loop diuretic increase the excretion of calcium. Loop diuretic increase the excretion of calcium. So but thiazide diuretics storing the calcium. And mannitol a osmotic diuretic. Chlorothiazide is a thiazide diuretic. It may lead to hyperuricemia. It may also lead to increase in calcium levels in the blood. Increase in calcium levels in the blood. Next. So regarding thiazide diuretic inhibits sodium chloride in water and estrazolamide inhibits carbonic anhydrase enzyme. And furosemide inhibits sodium potassium 2 chloride cotransporter. And mannitol is an osmotic diuretic, increase the urine formation and urine excretion by the mechanism of osmosis. So these are the list of the drugs we already gone through and what are their specific side effects along with their mechanism of action. Thiazide diuretics, so estrazolamide, and next is furosemide, and next is mannitol. Okay, next question. Ion trapping is an important process in drug distribution with potential therapeutic benefit. It is defined as ion trapping is an important process in drug distribution with a potential therapeutic benefit. It is defined as an acidic drug will accumulate on the more basic side of the membrane and the basic drug on more basic side. Okay, that is one option. And next option, an acidic drug will accumulate on the more acidic side of the membrane and basic drug on the basic side. An acidic drug will accumulate on the more basic side of the membrane and the basic drug more on the acidic side. An acidic drug will accumulate on the more acidic side of the membrane and the basic drug on more acidic side. So generally, if you know that, so like these questions are little bit confusing and little bit frustrating. Generally, for a drug, if any drug molecule should have excellent drug absorption, if any drug molecule should have excellent drug absorption, what it should be? So here, it should be lipophilic in nature, it should be unionized in nature, it should be weak acids or weak base in nature. For example, acidic drugs may have good absorption in the stomach region because acidic medium, the stomach region having acidic medium. And basic drugs are having good absorption. Basic drugs are having basic drugs are having good absorption in the basic region. because base become unionized. Unionized molecules only having good absorption and distribution. Basic anionizer form, acidic, unionized form. So acid base ionized, base as ionized. So that's why our molecule should be weak acids or weak bases. If they become strong acids or strong base, so sometimes they become ionized. Ionized molecules are having poor absorption distribution. The stomach region is having acidic medium. The intestine is having basic medium. So basic drugs are having good absorption in the intestine medium because of basic pH. Acidic drugs are having good absorption in the acidic medium, that is stomach. Okay. So here the answer will be the for this question. If you clearly observe, an acidic drug will accumulate on the more basic side of the membrane and basic drug more on the acidic side, because acidic side become ionized at basic, acid base become ionized. They will be there only, no movement, no pharmacokinetic. Okay, the answer is acidic drug will accumulate on the more basic side and basic drug more on the acidic side. So here you can clearly observe acidic pH environment. So at the acid environment, acid drug is non-ionized, unionized. At the basic environment, acid drug is ionized. At the basic environment, acidic drug is the ionized. At the basic environment, basic drug is the unionized. Base unionized, acid unionized. Unionized molecules having excellent absorption distribution as well as excellent pharmacokinetics. Let's have a look on the next MCQ. One of the following statement with respect to carbachol is not a correct one. Carbachol. So carbachol is a parasympathetic. Carbachol is a parasympathetic. This parasympathetic means shows action similar to acetylcholine. So, but carbachol may have action on muscarinic receptor and little bit nicotinic receptor action also. So, it can be administered orally, possess both muscarinic and nicotinic action. It is more susceptible to hydrolysis as compared to acetylcholine. The amino group decrease electrophilicity of the carbonyl group. So generally the drawback of acetylcholine, why carbachol, methanonicol drugs are designed. Acetylcholine is a good, but acetylcholine having short half-life. It is readily hydrolyzed by the acetylcholine esterase enzyme in the body. But here they mention it is more susceptible to hydrolysis compared to acetylcholine. But compared to acetylcholine, it having less hydrolysis. It having excellent half-life when compared to acetylcholine. That's why the wrong one is so acetylcholine is more susceptible to hydrolysis than the carbachol. Carbachol having a less hydrolyzing capacity, not rapidly hydrolyzed by acetylcholine esterase. So it will administered orally, having muscarinic effect action. It acts on nicotinic receptor, and the amino group decrease electrophilicity of the carbonyl group. Yes, here regarding acetylcholine esterase enzyme. So acetylcholine rapidly hydrolyzed by the acetylcholine esterase and little bit also by the butyrylcholine esterase. Methacholine very less and not by butyrylcholine. Carbachol also not readily hydrolyzed by these enzymes. Methanicol also having excellent half-life. And acetylcholine action on both muscarinic and nicotinic. Methacholine both muscarinic, nicotinic, and nicotinic very less. Betanicol action on muscarinic but no action on the nicotinic. Coming to carbachol, carbachol having more action on nicotinic compared to muscarinic. Next. So like these questions are very interesting if you have basics, essential basics as well as the concepts. So let's see the question. Which three of the following are physiological effects of ganglionic stimulants? So ganglionic stimulants are nothing but they stimulate the ganglia, especially NN receptors. Nicotinic neuronal type or nicotinic ganglionic types are NN receptors. NN receptors. So what are the effects? Which of the following three are effects of ganglionic stimulants? Stimulation of the sympathetic ganglia, the adrenal medulla leading to cardiovascular response. Initial transient stimulation, then more persistent depression of all autonomic ganglia. marked depression of CNS leading to analgesia. Chronic exposure causes marked increase in the density of nicotinic receptors, contributing tolerance and dependence. Combined activation of parasympathetic ganglia, cholinergic nerve ending by nicotinic result in increased tone motor activity of the body. Inhibition of salivary and bronchial secretion followed by the stimulation. So whatever it may be, so here many statements are given, but generally ganglionic stimulants nothing but they stimulate the NN receptors, that is nicotinic neuronal or nicotinic ganglion type. When these receptors are stimulated, what will happen? When these receptors are stimulated, it may lead to the stimulation of this receptor, but initially stimulation will take place, but further what will happen? There is a persistent stimulation, continuous stimulation of these receptors may lead to paralysis. So, if these receptors are stimulated, there is activation of both sympathetic parasympathetic nervous system. If these receptors are inhibited, there is a depression of both sympathetic and parasympathetic nervous system. So, generally, according to the statements, if you observe, the PQS will be the answer. Regarding the PQS, so what are the P? Stimulation of sympathetic ganglia and adrenal medulla leading to cardiovascular. So when nicotine enter into the body, it binds to nicotinic receptor. So when nicotinic receptors are stimulated on the adrenal medulla, there is release of adrenal gland. There is release of adrenaline. And initial transient stimulation, then more persistent depression of all autonomic ganglia. Initially stimulation will be there, but continuous action may lead to the depression of this NN ganglia, NN types of receptor. So depression of this NN receptors may decrease in sympathetic as well as parasympathetic functions. That is not good for the body. Next, S. Chronic exposure causes marked increase in the density of nicotinic receptors, contributing tolerance and dependence. Chronic exposure, continuous usage, long-term usage may lead to tolerance and dependence. Chance of patient depend on the drugs may lead to addiction. Tolerance, decreasing responsiveness of drug, decreasing effectiveness of the drugs. Next. Yes, stimulation of sympathetic ganglia and adrenal medulla leading to cardiovascular things. So we already discussed here. Next. Generally, which class of non-steroidal anti-inflammatory drugs? So here there is a little bit confusion in the question. So what are the examples of like preferential COX-2 inhibitor? The question is about what are the examples of preferential COX-2 inhibitor? Generally, preferential COX-2 inhibitors like so pyraxicum. So Pyraxicum is having preferential COX-2 inhibitor. So more action on COX-2 and little bit less action on the COX-1. And the ratio is about 10 is to 1. 10 is to 1. So here non-selective COX inhibitor. So classification of NSAIDs, salicylates, aspirin, propionic acid derivatives, caronic acid derivatives, enolic acid pyraxicum, tanaxicum, acetic acid derivatives, pyrazolone derivatives. So here preferential COX-2 inhibitor, nimsolide, dialclofenac, meloxicam, metodalac, esiclofenac, and selective COX-2 inhibitor like celecoxib, vetroxib, paracoxib, bromodoxib, and analgesic antipyretic with poor anti-inflammatory derivatives. Okay. Next. So regarding the next question, which of the following is not the property of osmotic diuretic? So undergo limited reabsorption by the renal tubules, are relatively inert pharmacologically. They inhibit the carbonic anhydrase, freely filtered at the glomerulus. So these are the osmotic diuretics. Their main mechanism by the process of osmosis to eliminate the excess fluid from the body through the urine. So, but yes, they undergo limited reabsorption only. They directly eliminate through the kidney. Relatively inert. They are not having any pharmacological action. Their physical action is osmosis. By the osmosis, excreting more fluids to the urine to outside of the body. They inhibit the carbonic anhydrase. No, the azide diuretics can inhibit the little bit carbonic anhydrase enzyme activity. Loop diuretic also little bit, but carbonic anhydrase inhibitor, estrazolamide, dazolamide, brinzolamide, highly inhibitory effect on carbonic anhydrase, decrease the Sodium and water absorption into the body, inhibition of carbonic anhydrase. So osmotic diuretics do not inhibit carbonic anhydrase enzyme. So the answer is option C is the answer. So they are pharmacologically inert, generally non-metabolized, directly eliminated through the urine. So Manita, one of the commonly used osmotic diuretic, increase the plasma osmolarity, shift the fluid from intracellular fluid to extracellular fluid, increases extracellular fluid volume, increase the urine formation, and increase the water diuresis. Nothing but increase the urine formation and increase the excretion of urine to kidney. Increase excretion of urine to the kidney. Next. Next MCQ is two pore domain potassium ions are opened by which one of the following category of anesthetics? Two pore domain potassium ion channels are opened by which one of the following category of anesthetics? So anesthetics are nothing but they cause loss of sensations, loss of reflexes. So that is the secondary scenario for us. So barbiturates, benzodiazepines, opioids. So barbiturates are GABA A receptor agonist, conducts Cl minus ion channel. Benzodiazepines also GABA A receptor agonist, conduct Cl minus ions. Opioid analgesics acts to the mu K delta receptor. Mu K delta receptor. They are opioid receptor, inactive Gpat receptor, and halogenated inhalation anesthetic like halotheno, enflurano, isoflurano. They opens two pore domain potassium channels and increases efflux movement of potassium from inside of the cell to outside of the cell. So movement of potassium from inside of the cell to outside of the cell decrease the positive voltage within the cell membrane, increase the negative voltage and develops hyperpolarization and produce anesthesia. That is resting stage of the cell membrane. Okay, the answer is halogenated inhalation anesthesia. Halogenated inhalated anesthesia. These are the drugs opens two pore domain potassium ion channels and helps in anesthesia mechanism. Helps in the anesthesia mechanism. Okay, so here is the explanation. Volatile agents potentiate GABA receptor and two pore potassium channels, whereas NMDA channels are blocked by ketamine as well as nitrous oxide. So nitrous oxide, ketamine block the NMDA receptor. NMDA, N-methyl deaspartate, one of the excitatory neurotransmitter of glutamate subtype. Glutamate subtype. Next, which one is not an opioid receptor? I hope this is very easy. So there are only three opioid receptors are there. So mu, kappa, delta. These are the three types of opioid receptors belongs to Gpat couple receptor. When opioid receptors are stimulated, they activate inactive Gpatins, decrease the pain perception by decrease the neurotransmission in the nerves. So the answer is very clear. So gamma is not a type of opioid receptor. Kappa, mu, delta are opioid receptor. These are the opioid receptor. And all opioid receptors are Gpat couple receptor. So respect to opioid receptor, mu receptor and their functions, kappa receptors and their functions in the body, delta receptors and their functions in the body. So let's go through once. You will have some idea. And if you have the question, you can answer easily. Next. Identify antiarrhythmic drug that increases duration of QT interval and decrease the sinus rate, whereas it has no effect on the QRS complex. Whereas it has no effect on the QRS complex. It has no effect on the QRS complex. So example like lidocaine, amiodarone, verapamil, meridine. So all these are antiarrhythmic drugs, but here the question is it increase the duration of QT wave, but decrease the sinus rate, but no effect on the QRS complex. On the QRS complex, the drug with no effect is amiodarone. So amiodarone is a class 3 antiarrhythmic, block the potassium channel, and amiodarone is regarded as a broad spectrum antiarrhythmic, can block sodium channel, potassium channel, calcium channel. Okay, the answer is amiodarone. And amiodarone is having long half-life, nearly months also. So regarding the amiodarone is selectively block the potassium channel, also block sodium and calcium channels non-selectively. So lidocaine is a class 1 antiarrhythmic, verapamil class 4 antiarrhythmic, pyridine is also class 1A antiarrhythmic, class 1A antiarrhythmic. So especially prolongation of QT interval develops torsade depointers, that is ventricular tachyarrhythmias. Ventricular tachyarrhythmias, that is torsade depointers, due to prolongation of QT interval. These torsade depointers are ventricular tachyarrhythmias can be treated by magnesium sulfate. Can be treated by magnesium sulfate. Next, autorhythmicity. Autorhythmicity is present in which of the following group of the tissues? So skeletal muscle, cardiac muscle, skeletal muscle, visceral smooth muscle, cardiac muscle and neuronal tissue, and cardiac and visceral smooth muscle. So cardiac muscle should be there. You know that cardiac muscle should be there. In the option B, there is a no cardiac muscle because cardiac muscles and smooth muscles are generally having automaticity. They can generate their own rhythm by their own automaticity. So the answer is cardiac muscle and visceral smooth muscles are generally having automaticity or autorhythmicity property. They can generate their own rhythm. Their own rhythm. Next. Cardiac muscle fiber has automatic rhythmicity. It is a contractile tissue present only in the heart. It is a contractile tissue present only in the heart. And when one cell in cardiac tissue receives a signal contract, its neighbor cells also receive that property. So excitability, autorhythmicity, conductivity, contractility. So contractility nothing but contraction, inotropic action, increasing number of contractions or force of contraction. Conductivity, passing the signal. So in the heart, one place the rhythm is generated that will be shifted to the whole heart. Conductivity, conduction, passing, and autorhythmicity can generate impulses on own. Excitability, stimulation of the cell, excitability. Okay, next MCQ. So next MCQ regarding D-tubopyramid. D-tubopyramid. So regarding the D-tubopyramid, so D-tubopyramid is dextro form of tubopyramid. It is one of the drug from the plant derivative. And this D-tubopyramid, what it is doing? The D-tubopyramid is doing that. It generally a neuromuscular blocker acting peripherally acts by blocking nicotinic muscle receptors on the skeletal muscle. That is what neuromuscular junction, a junction between neuron and the muscle. So D-tubopyramid produces skeletal muscle relaxation by inhibiting ganglionic nicotinic receptor. So ganglionic drug blocking ganglionic receptor, it acts on the NM, but it is a muscle relaxant. It is acting on NM, nicotinic muscle receptor. Muscarinic receptor, no. Nicotinic receptors in the neuromuscular junction. Alpha adrenergic receptor. So D-tubopyramid is a peripherally acting neuromuscular blocker. It acts on the neuromuscular junction. Block the nicotinic muscle receptors present between the motor neuron and muscle, that is neuromuscular junction, skeletal muscle. So D-tubopyramid acts by blocking nicotinic muscle receptors in the parasympathetic nervous system. Yes, the D-tubopyramid is naturally from the chondrodendrotomentosome, and among all D-tubopyramid is the most important alkaloid. It blocks NM receptors and produces muscle relaxation, skeletal muscle relaxation. Neuromuscular blockers are mainly used during condition of surgical procedures. Because of prominent histamine releasing, ganglionic blocking and cardiovascular action as well as long duration, paralysis needing pharmacological reversal. Pharmacological reversal. Okay. Yes, it is a block neuromuscular, nothing but nicotinic muscle type of receptor. Maybe little bit blocking of NN receptor. And one of the drawback, D-tubopyramid may increase the release of histamine and produce allergic reaction. A idiosyncratic reaction, D-tubopyramid may increase the release of histamine that may lead to increased allergic reaction. Increases allergic reaction due to excess histamine release. Next. Next question is, which of the following is not one of the triad effect of adrenaline leading to rise in the blood pressure? Which of the following are not a which of the following is not one of the triad effect of adrenaline leading to the rise in the blood pressure? So let's have a look. A direct myocardial stimulation of that increase the strength of ventricular contraction. A increased heart rate positive chronotropic, number of beats increases. Vasoconstriction in many vascular bed, especially precapillary resistance vessels of the skin. Stimulation of presynaptic alpha 2 adenoreceptors leading to increased lymphatic flow. The simple logic, alpha 2 receptors are autoreceptors. When autoreceptors are stimulated, they inhibit the release of their own neurotransmitter. They inhibit the release of their own neurotransmitter. So decrease the noradrenaline release. Decreasing noradrenaline release due to alpha 2 receptor stimulation. If no noradrenaline, no rise in the blood pressure, no rise in the heart contractions. If no heart contraction, no increase in hypertension as well as the blood pressure. Which of the following is not one of the triad three effects? Among these four, three are increasing the blood pressure, but one is not. The one is alpha 2 receptors decrease the noradrenaline release, decrease the blood pressure, decrease the blood pressure. Simple logic. So, if you have the basics and concepts, you can filter easily. You can filter easily. Yes, answer is option D. So alpha 1 receptor stimulation, generally what will happen? Alpha 1 receptors present of the blood vessel. So excess stimulation of alpha 1 receptor increase the blood pressure. That's why alpha 1 blocker Joseph as an antihypertensive. Alpha 2 receptor stimulation decrease the blood pressure. That's why alpha 2 receptor agonist fluoride as an antihypertensive drugs. Beta 1 receptor stimulation increase the heart rate, increase the blood pressure, nothing but hypertension. And beta blockers like propranolol as an antihypertensive drugs. Beta 2 receptor stimulation generally helps in treatment of asthma, like salbutamol. Okay, so you can go through this explanation also, you'll get some extra knowledge. Next, which are the following drug? Next, which are the following drug possess anti-platelet effect? Which are the following drug possess anti-platelet effect? So erythropoietin is a peptide hormone from the kidney releases in hypoxia to increase the RBC production, red blood cells formation. Erythropoietin promotes erythropoiesis. And urokinase, streptokinase, they are fibrinolytics. They break down the formed clot. Desmopressin is a vasopressin analog, shows action similar to antidiuretic hormone or vasopressin. So clopidogrel, a antiplatelet drug, prevent the aggregation of platelets by blocking P2 white-12 purinergic receptors or adenosine receptors. Adenosine receptors. Next. So P2 white-12 receptor blockers, like chemically they are thionopyridine derivatives. They inhibit adenosine diphosphate mediated platelet aggregation by irreversibly blocking the purinergic receptors on the platelets. So on the platelets there is a receptors adenosine or purinergic receptor. Blocking of this receptor prevent aggregation of one platelet with the other platelet. So these are the this is the classification: thromboxane synthesis inhibitor, aspirin, platelet cyclic AMP enhancer, dipyridamol, and beta white-12 blockers, glycoprotein 2-BR3A antagonist, and prostaglandin I2 analogs, and PAR, protease activated receptor antagonist, warfarin. So these are the list of the anti-platelet drugs, prevent the platelet aggregation and decrease the clot formation. Next. Okay. So urokinase, erythropoietin, desmopressin, I already informed in the MCQ itself. Next. Next regarding which one of the following is a organ specific autoimmune disease? Which one of the following is a organ specific or localized autoimmune disease? So mostly all these are autoimmune disease, but they are clearly mentioned specifically related to the organ. For example, Graves' disease related to thyroid gland, scleroderma related to skin, polyarteritis nodosa related to artery, rheumatoid arthritis related to the joints. So simply here, Graves' disease related to the organ, that is thyroid gland, Graves' disease. Is an autoimmune disease of the thyroid gland. Answer is Graves' disease. So here, organ specific systemic autoimmune disease. Systemic autoimmune disease, rheumatoid arthritis, scleroderma, systemic lupus erythematosus, primary Sorensen syndrome, polymyositis. So Soren syndrome is nothing but destruction of salivary glands, decreasing saliva production. And next, autoimmune organ specific like type 1 diabetes related to pancreas, good fascial syndrome, multiple sclerosis, Graves disease, Hashimoto's thyroiditis, a autoimmune disease, and autoimmune disease, Addison's disease, vitiligo. These are the list of example of organ specific autoimmune diseases and systemic autoimmune disease related to the blood and blood related. Where blood will go, there will be a chance of autoimmune disease. So, like systemic lupus erythematosus, it is related to the systemic circulation, vascular system. Next, which of the following neurotransmitter? Which of the following neurotransmitter is formed on demand and act immediately? Which of the following neurotransmitter is formed on demand and shows action immediately? So, generally, acetylcholine, histamine, nitric oxide, adrenaline. So regarding this question appeared in the 2020 Gpat question paper. So the answer is nitric oxide. The nitric oxide produced on the demand basis and shows action immediately. Nitric oxide is a potent vasodilator. Dilate the vascular smooth muscles on the blood vessel and produce vasodilation. Helps in reduction of blood pressure. This nitric oxide is also known as EDRF. What is the meaning? Full form of EDRF? Endothelium derived relaxing factor. Endothelium derived relaxing factor. Next, nitric oxide. Synthesized on the demand and immediately diffused out of the cells and other neurotransmitters. They are sensed in the constant manner. They are stored in vesicles and released by exocytosis. Exocytosis. Next. The next question is which of the following statement is true for the cancer cells? Which of the following statement is true for the cancer cells? Oncoproteins produced by cancer cells act a neighboring cell. Oncoproteins produced by cancer cells, they can act like a neighboring cells. Neighboring cells. Cancer cells require stimulation by growth factors. Yes, epidermal growth factor, increase epidermal growth, platelet derived growth factor, nerve growth factor, vascular endothelial growth factor, transforming growth factor. Excess functioning of growth factor increase the cell division, increase the tissue formation, and excess tissue leads to abnormal tissue and the cancer tissue. Next, cancer cells are highly sensitive to growth inhibitory signals. Cancer cells produce oncoprotein in the absence of growth factors or external stimuli. So, among these, which of the following statements are true statements? So, which one of the following statement is true about cancer cells? True about cancer cells. So, regarding the true is cancer cell produce oncoproteins in the absence of growth factors or external stimuli. Without external stimuli, without influence of growth factor also, cancer cell produce oncoproteins which may increase the further spreading of cancer or increasing the cancer growth. Answer is option D. Option D. So here hallmarks of cancer along with their explanation. Cells self-sufficient in the growth signals, so they can stimulate like heart how generating its signal and self-sufficiency and intensive to anti-growth signals. Intensive, so they suppress the anti-growth signal and promote their growth. Evading apoptosis. Cancer cells resist their programmed cell death. Generally, programmed cell death is common in the body, but cancer cells oppose the apoptosis and helps promote their growth. Limitless replication. They can replicate continuously because of that forms a large cancerous tissue. Large cancer tissue. Sustained angiogenesis. So they maintain the sustained angiogenesis. Angiogenesis, formation of a new blood vessels. Formation of a new blood vessels from the cancer cells increase the risk of cancer spread of the cancer. Tissue invasion metastasis. They can easily spread from one part to the other part through the blood or they can easily spread, invade, penetrate from the one tissue to another tissue. These are the hallmarks of the cancers with their explanation. So this table also, once you go through it, you will get some idea. Next, next question is, in one of the following situation, metabolic acidosis does not occur. In which of the following condition, generally metabolic acidosis does not occur? Uncontrolled diabetes mellitus, therapeutic administration of estrogen, chronic renal failure, production of less amount of lactic acid. In one of the following situation, metabolic acidosis does not occur. So, uncontrolled diabetes mellitus may increase the ketone bodies, especially lactic acid, increase acidic content. Therapeutic administration of estrogen. Excess usage of estrogen may develop the condition. Chronic renal failure also may lead to change in the pH of the fluids and may lead to acidic pH. And production of less amount of lactic acid. Generally, if lactic acid amount is less, automatically no lactic acid, no rise in the acidic pH. No rise in the acidic pH. One of the following situation. Okay. Yes, our answer will be the option D. So a fall in the so generally a fall in the blood pH due to metabolic component is brought about by fall of bicarbonate level, excess H plus ions in the blood. Generally, blood pH is 7.35 to 7.45. So falling means decreasing means towards the acidic pH. What are the reasons to rise in the body fluid pH or blood pH towards the acidic side? So especially increasing carbonate levels and decreasing carbonate levels, increasing proton levels, develops this condition. So there are many conditions like production of large amount of lactic acid in vigorous exercise, shock, uncontrolled diabetes mellitus, diabetic ketoacidosis, starvation, chronic renal failure, therapeutic administration of ammonium chloride or acetylbromide may increase the metabolic acidosis, shift body fluid pH towards the acidic side. If acidic pH is increasing, it may increase the damage of body organs as well as tissues like ulcer, excess production of HCl. Excess production of HCl, what is happening? Excess production of HCl leads to gastric ulcer. Next. The next MCQ is, in the transplant rejection, nothing but organ transplantation rejection, the clinical features of the graft versus host reaction include following except. Include following the except. In the transplant rejection, the clinical features of graft versus host reaction includes following except dermatitis, diarrhea, fever, weight loss, intestinal malabsorption, rheumatoid arthritis. So here, organ transplantation, for example, some heart transplantation, one person heart is enter into the other person heart. Even a small pathogen enter into the body, our immune system will oppose that. But that much organ enter into the body, our immune system try to oppose. So if this opposing function is happening, that is known as rejection. So the organ is not fit into his body. Immune system is reacting over. That is organ transplant reaction. So here the question, in the transplant rejection, the clinical features of graft versus host reaction include following except, that is rheumatoid arthritis. The exception is the rheumatoid arthritis. So let's see the explanation. You will get more idea. So what is simply first graft versus host disease? A complication that occur after an allogeneic transplant where immune cell from the transplanted graft attack the recipient tissues. The clinical features of graft versus host disease typically include. Next. Okay. So the clinical features of graft versus host disease include dermatitis, diarrhea, fever, weight loss, intestinal malabsorption, liver dysfunction, mouth sores, eye irritation. Rheumatoid arthritis is not typically associated with this graft versus host disease. Graft versus host disease. Next. Which one of the following is not a renal osteodystrophy type of bone disease associated with chronic kidney disease. Which one of the following is not a renal osteodystrophy type of bone disease associated with chronic kidney disease? Chronic kidney disease. A dynamic bone disease, osteomalacia, secondary hypoparathyroidism, mixed renal osteodystrophy. So osteodystrophy, so destruction of the bone tissue or decreasing the size of the bone tissue. Okay, so that is the meaning. And here, the dynamic bone disease, osteomalacia, secondary hyperthyroidism, mixed renal osteodystrophy. Mixed renal osteodystrophy. So what is the answer here? So the answer is secondary hypoparathyroidism. So which one of the following is not because of kidney disease? That is secondary hypoparathyroidism, decreasing parathyroid hormone, decreasing parathyroid hormone, secondary hypothyroidism. So here dialysis related, uremia related. So types of renal osteodystrophy, types of renal osteodystrophy, dialysis related, uremia related. Next, renal osteodystrophy. It is a metabolic bone disease. That is, renal osteodystrophy is a loosely used term. Sorry, usually used term that encompasses a number of skeletal abnormalities appearing in case of chronic kidney disease and patient treated by dialysis for several years. So, simply renal osteodystrophy nothing but term encompasses number of skeletal abnormalities appearing in cases of chronic kidney disease and in patient treated by dialysis for several years. Dialysis for the several years. Next. Identify the phase of clinical trial having following features. Which are the following clinical trial having these features? So here, identify the phase of the clinical trial having following features. Trial is conducted on nearly 3,000 patients, so large number. Definitely this much large number you can upload in case of generally phase 3. Purpose of trial is a therapeutic confirmation. Yes. Safety and tolerability evaluated on the wide scale. Completion of trial is followed by new drug application. So once the trial is completed, go for the new drug application NDA. So this will be after phase 3 only. So 3,000 volunteers, therapeutic confirmation, safety and tolerability, completion of trial followed by new drug application. New drug application. New drug application like phase 3, phase 1, phase 4, phase 2. Answer will be the phase 3. Answer will be the phase 3. So here, drug discovery, preclinical phase in the animals, clinical trials in the humans. After that, regulatory approval. After that, entry into the market, post-marketing trials phase 4. In the phase 4 also, the drug will be observed for the 2 years regularly at 6 months of interval. Regularly at 6 months of interval. Next, which of the following is not affected in the respiratory tuberculosis? Which of the following is not affected in the respiratory tuberculosis? As you know that tuberculosis is caused by Mycobacterium tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. A. Acid fast bacterium respond to acid fast staining, also known as Gill Nelson staining. And tuberculosis is mainly affect the respiratory system, nothing but lungs. But here options are like pleural cavity, that is lung, mediastinal lymph nodes. Yes, through the lymph also the tuberculosis will be passed mycobacterium and pericardium larynx. So pericardium is related to the heart. Pericardium is related to the heart. The answer is the pericardium. Pericardium is a part of a heart, but it is not a part of lungs. It is not a part of lungs. So this is types of tuberculosis: pulmonary tuberculosis, extrapulmonary, miliary. So pulmonary in the lungs, extra out of the lungs, and miliary tuberculosis. So carried to all parts of the body through bloodstream. Miliary tuberculosis means carried to all parts of the body through the bloodstream. So example, but generally miliary is rare. Miliary is rare. Most common is pulmonary tuberculosis. Pulmonary tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis and also combination of MAC, Mycobacterium avium complex. So this is regarding our discussion on the 2020 pharmacology questions from the previous year Gpat paper. I hope you are really very serious on your preparation. So please make it continue. And the essential thing is the 3 hours what you are going to do. The 3 hours what you are going to do is very critical and essential. So stabilize your psychological system. So keep focus on your paper. So how the questions are they given, study the questions first, and always follow the filtration mechanism. So why the correct answer is why, and why remaining three are wrong. So please follow this filtration and don't waste your time at difficult questions you are feeling you don't know the answer also, and decreasing the guessing of answers also. So everything will be going well, nothing to worry. So what your hard work you are doing since last few years or last months, it will be going to worthy. So please be calm, be try to be in the reality, try to be in the exam without any over excitation, over depression, and stabilize yourself. And once again, all the best to all of you for your Gpat 2020 examination. Thank you. Subscribe to GDC English classes.